Hope everybody had a good lunch. Aiden, can you, first of all, I want to make sure, can you guys hear me? Okay,
Can hear.
good. Aiden, can you put the questions up from the exam? Okay, so let me go over those. So question number one was altered drug response seen with chronic disease can be due to, and the correct answer here was all of the above. We talked about there can be altered pharmacodynamics due to either due to the disease. We talked about altered pharmacokinetics, several aspects there, and then also by progression of the disease. Pretty straightforward. Question number two, the World Health Organization recognizes age as a chronic disease condition, and the answer here is false. In the first slide I showed you, it showed chronic disease conditions, and I had the word age, but as far as a World Health Organization, they don't include it on their list. Three, alterations in temperature sensitivity is associated with or can be associated with alterations in pathology. That's correct. And it also can be associated with an age-related alteration. So the correct answer is C. So, so again, all of the answers again should be: one is D as in dog, two is B as in boy, and three is C as in Charlie. Okay. And I'm going to tell you guys is my voice is coming and going. So we're going to go as far as we can, but I'm going to move through some of this stuff a little bit quick because I thought it was doing pretty good this morning, but right now it's coming and going. So we'll do the best we can. So if y'all don't hear me or I need to follow up on something, let me know. And then let's start with diabetes. So diabetes is well recognized issue. Estimated that probably over 340 something million diabetics worldwide. We see a lot of complications with diabetes. Primarily, many of it is secondary to hyperglycemia, but we also see that diabetes is associated with other diseases. We see it associated with blindness. We see it associated with cardiovascular disease. We see it with renal failure. So there's a lot of complications that arise with diabetes. It's considered, and many individuals consider that probably the most psychologically and behavioral demanding chronic medical illness, because as we mentioned when we talked about diabetes, we can't control blood sugar with insulin. There's no way, even with pumps and our modern technology, we even run to the point where that it just basically is not going to be able to match what the body does. So what we find is individuals are constantly stressed with regard to, I have a lawyer acquaintance that I know, he's been on the other side of me, taken my deposition number of times, and I always tell him he is the most disciplined diabetic I've ever known, but because he's constantly checking his insulin, he's constantly doing everything, he's being very, very cognizant of that. But most individuals, we find that this constant taking blood, checking their blood levels, making sure their insulin is there, watching what they eat. So this creates a lot of problems. This high stress puts them at a higher risk for things such as depression and anxiety. And that can even make, can even make things worse because that puts even a higher demand on them. So when they get stressed, what we see a lot of times, diabetics can actually will lose motivation for self-care. The stress just gets too much for them. What we see is that they don't pay attention to the diabetic cues. That's very important for them to pick up their cues from their body as to where their glucose is. And then we see that in their normal lives, they take on risky behaviors. It's almost like they control and go for a while, but then they go out and I've seen a number of diabetics that will go out and drink alcohol and binge drink or food binge, and that can create significant issues. when you don't have adequate blood glucose, think of all the things, all the tissues that need glucose to function, particularly in, the brain. And the other thing that we see is that if you're not controlling your glucose, we see a lot of diabetic complications. And I've seen a number of these individuals where that they have developed diabetic complications. We had a guy that went to our church that was a diabetic. He was type 2 diabetes. He was overweight. He had a long-standing diabetes. He was a former law enforcement, and then he was working as a janitor. And he would constantly eat fast food and so forth. His diet and his exercise was very minimal. And so he basically had a fairly sedentary lifestyle. It wasn't as if he was a couch potato all the time, but he was not near active at a level that was continuous to that you would consider as a moderately active person. He developed an infection due to his, he didn't drink, but he did a lot of food binging. And he developed an infection in his foot, had to have 3 toes amputated. The infection was in the actually bone of the tissues. So there was the financial stress of, we worked to get him appropriate care because he couldn't afford it. Then after coming, and then he went through this whole thing about being out of work because, and his family not being taken care of. Even when the church was stepping in, there was a lot of discussion with regard to, with him, of concerns with regard to, his adequacy of being able to provide and so forth. He got the surgery, was a pretty complicated surgery, fairly long recovery, several weeks recovery. 6 months later, we were back to where he was back to his old lifestyle. So even with significant diabetic complications, which resulted in, significant disability and him being without work, it created issues. And that just, it was like this catch-22. So there's been a number of studies, this study back in 2001, when you look at diabetic and non-diabetic and the prevalence of depression, what you see is that diabetics have a higher prevalence, even with type 1 and type 2 combined diabetics. But we see that males have a higher, male diabetics have a higher incidence of depression, and female diabetics is way up there. Type 1 diabetics, which are the juvenile onset, are high, and type 2 is fairly significant. So most people would estimate the prevalence at 15 to 25%, which can be significant. So this puts an important thing. And if you think about it, if we're treating depression, if we can put counseling with it, coupled with drug therapy, we should be pretty successful with this. And again, these diabetics are lifelong, and this is going to control that. But what we do see is, and this seems common sense, diabetics tend to have a greater cognitive impairment. If you think about it, your brain needs glucose, and if you're not regulating glucose, then you would anticipate that to be a greater cognitive impairment. In particular, Watari basically determined that the greatest impairment seemed to be with their ability for maintaining attention and processing information and executive functioning. So clearly there's a need for treating these patients. One thing that we see is many times treatment falls right into drug therapy. And what we see is that these individuals may not, maybe be treating by, by a general practitioner and may never see a psychologist or a psychiatrist. We see tricyclics. One of the common things with diabetes, as you know, is neuropathy. And we see that the tricyclic antidepressants are effective with the neuropathy and may also have an antidepressant effect. But the other thing we see is that these tricyclics may actually produce postural hypotension, which can be an issue. And it can also produce gastroparesis. And what gastroparesis is basically you have altered movement of things through the stomach. And gastroparesis can produce a lot of indigestion, can produce acid, can impair normal functioning and glucose control there. The tricyclics can actually make it worse. And we also see the tricyclics may interfere with glycemic control. So although the tricyclics seem to be important for the diabetic neuropathy, they come with a big problem or a lot of disadvantages. Now, moving to the SSRIs, which we see has occurred more frequently, again, the TCAs, the tricyclics, seem to be more associated with use for diabetic neuropathy. But there's been some evidence that SSRIs may also be effective there too. We do see the SSRIs in patients that are diabetic, that it does improve the depression, which is what we would anticipate, and also improves glycolated hemoglobin. The glycolated hemoglobin is our best index for long-term control. And one of the things that may happen is when people are feeling better and not depressed, they may take care of themselves. There's been a couple of other drugs that may have some antidepressant actions, venlafaxine and duloxetine. Again, antidepressants, but there's been a few things that have suggested they may be effective for neuropathic pain. Anxiety, we see a lot of anxiety in diabetics. They have, what they worry about is what happens if I develop hypoglycemia, especially if, I am in a situation where that I can't, address it. They worry about diabetic complications, potential of a heart attack, development of gangrene, development of neuropathy, loss of limbs. Sometimes the family creates a lot of tensions. One of the reasons for that is they sometimes are, trying to take care of them, but it can put unusual and unrealistic social tension there. And then again, every day is a new challenge for these diabetics. Trying to figure out exactly what's going to happen, or each day these new fears come up and so forth. Many individuals, what we see, are actually underdiagnosed and treated and undertreated. Many times they can't tell the difference between anxiety and hypoglycemia. The signs of hypoglycemia are autonomic effects there. We got somebody that is, Aiden, if you could, I think we got somebody that's their mic is not muted, picking up some background there. But what we find is that it's hard to tell whether you're just stressed or if you're developing hypoglycemia. And the fear of hypoglycemia is that, they could, potentially die from that. So what we find is that also the more stressed people are, the more difficult it is to manage their diabetes. And a lot of times we see when someone is not, it's a shocker for someone to be given the diagnosis of diabetes and for them to have to deal with it. This is a good example of where psychology, basically psychologists and psychiatrists could interface very well here. Now, I've put a couple of slides in here you guys have seen before. These are good review slides for you because what they do is when we're looking at antidepressants, one of the things we see is that if they block the norepinephrine transport, you can see some of the adverse effects that they occur. So, for example, if we're looking at a diabetic, one of the things that we might see is the individual, the drug may produce tremors or tachycardia, or may actually enhance the effects of any sympathomimetic they may take. Sympathomimetic, think of things like over-the-counter cough, cold preparations, decongestants. So these signs could very well be, the tachycardia, the tremors, these could very well, or even the enhanced effects of sympathomimetics could be thought of as being hypoglycemia. Orthostatic hypotension, it doesn't, the person may be thinking they're fainting. Sedation and weight gain may be a reason why a person may not take a drug that has some antihistamine effects. Think about this, many of the tricyclic antidepressants will have these type of actions. And you have to look at these things. Blurred vision, a person may think of as something that it's the diabetes. So these are concerns that we have that's coming in here. And same thing with the serotonin transport blockers. You've seen this slide before. There's the side effects, and things like agitation, anxiety, panic attacks could very well be interpreted as an aspect of hypoglycemia. The other thing keep in mind is that there can always be drug interactions with any of these drugs. And again, remember that 2D6 and 3A4 are the most common where we've got. And just the ones that I want to point out to you a little bit that I think are very important for you to know, especially with somebody that's got a chronic disease, whether it's diabetes or the others. Always keep in mind cimetidine, which is an over-the-counter acid reducer, Tagamet. Preferably, you don't want your patients using that because there's so many potential drug interactions that can occur. You see some of the substrates that you would prescribe, and cimetidine could inhibit those and cause those drugs to not be metabolized. But then on the other thing, keep in mind grapefruit juice also. So grapefruit juice can inhibit 3A4. As far as inducers, St. John's wort, common over-the-counter, can induce 3A4. And we also see people that smoke or even char-grilled meats can induce 1A2, but I think you have to have quite a bit of activity there. This is another review slide for you guys that basically is very good, which can show you, if you look at blockade of these particular receptors that are in the far left-hand side, basically you can give what the side effects are. So by blocking D2, you can get the extrapyramidal effects. These are up in the brain. You can get galactorrhea, gynecomastia, sexual changes. 5-HT2C can be a weight gain. We can get that, but these last ones down here we see with a lot of the drugs. H1, blocking histamine 1 receptors, gives you sedation, and you can get weight gain due to increased appetite. Blocking the muscarine receptor, that's the anticholinergic actions, and then blocking alpha-1 can give you some postural hypotension. So again, these slides are really for you to help you study and put some things into context with chronic diseases as you use the drugs that you've talked about in previous classes. All right, let's move to another condition, which is obesity. We have gotten heavier. The United States, in fact, there's been discussions about changing the criteria for obesity, but we have seen a constant increase in weight. In 2008, it was estimated 1.5 billion adults using 20 or older as adults were overweight. And this next figure, the next one, 43 million children under the age of 5 were overweight. That's pretty significant when you start kids off early in life and are already overweight. So what's the consequences? Most people know if you're overweight, you're higher risk for cardiovascular disease, taking in a lot of lipids, heart's having to work harder to pump blood through the blood vessels and the fat. You're at more of a risk for diabetes, which makes cardiovascular disease even worse. People don't think about this with obesity, but musculoskeletal disorders. You're carrying more weight. One of the things, if any of you have done any of these exercise programs, if you want to sort of emphasize, take and put, your backpack or whatever, throw a 5-pound weight in the back of it. Carry it around during the day and see how much of a difference it makes. There is a lot of these. The other thing is that not only do you have the weight, but what you're running into is that individuals that are heavier have a harder time getting up, moving. Once they're easy to lose their balance. They're not as fast. There's a lot of things. If you think about, you know, if you're overweight, and especially as you get older, there's a lot of effort put into your normal movement. Puts a lot of stress on your joints. That's where we get osteoarthritis. Think about it as you're carrying all that extra weight. We're talking about obesity. We're talking people that are, 20, 30, 40 pounds or more that are carrying weight around, that's putting extra weight on their knees, on their ankles, on their hips, on their spine. We also see that there's risk for, when you're obese, that certain cancers are more prominent: endometrial cancer, breast cancer, colon cancer. Some of that is due to the hormonal actions that get produced. For example, with fat, the fat can produce estrogens. Then we have cancer as an important chronic disease. We see lung cancer, stomach cancer, liver, colon, and breast. Probably, and now we're starting to see, of course, some of it gets more media attention, but with Alex Trebek, Patrick Swayze, we've seen pancreatic cancer move up there. But as far as, pancreatic cancer we would have a very short, once it was diagnosed, it was not a long period of time for that to occur or for them to live. But we have gotten better with our chemotherapy. We have been trying to promote early detection on this, but there's a number of other cancers that are there too. So when you're dealing with cancers, one of the things that you see is that cancer patients are on multiple drugs. They're on their chemotherapeutic drugs. Those chemotherapeutic drugs create a lot of issues. Okay, there's such a thing as chemo brain. It is a real thing. We see that many times they're on an antiemetic. And, really the antiemetic that has really turned things around has been Zofran. Some people have still promote marijuana and marijuana derivatives. We've had a synthetic marijuana out there called Marinol, and actually on head-to-head, Zofran probably does a much better job. Many of these cancer patients are going to be on pain meds. A lot of them are susceptible to secondary infections because the chemotherapy interferes with their blood cells. And so the antibiotics, they're on there. So you've got to deal with drug interactions with potential antibiotics or even side effects with the antibiotics. The pain medications, many times we're looking at, people are trying to come out with some additional non-narcotic pain medications and non-opioid medications. But there's mixed feeling with regard to these other drugs and how well they work. I will tell you that on pain medications, a lot of doctors are getting, you see, oncologists tend to prescribe larger amounts and seem to be more comfortable with that. Other doctors have started watching how much they prescribe. So this is going to be a continual issue, especially since the California, I think, did this thing about where that if your patient, if you had prescribed an opioid and your patient dies, that they notified you. That was a team that was, or a tool that was designed to increase awareness so that physicians would be a little bit more cautious. But it got carried to another step where that the people started investigating doctors that were prescribing if you had a patient that died. One of the things you have to worry about with pain medications is sometimes if you have a patient that has a family member that's a cancer patient, is sometimes they will abuse their drugs. We do see that depression is a big thing in cancer. The word cancer, it's called the C word a lot of times, basically can create a lot of issues. So we find the younger the age, the greater the depression. Here you have a young person, and a lot of people still think that cancer is a death sentence. We have had some cures. As the person gets sicker, depression is more at a risk. Advanced stage, sometimes, we're trying to detect people at a much earlier age with cancer. But sometimes, like with my daughter, when she was diagnosed, she was already stage 4. 3 or 4 people that we know in association with my daughter, that we either knew through my daughter or was my daughter's friends, were diagnosed as stage 4. So when you get, stage 4, your options of, I think mortality becomes more of a concern. Your options of treatment, typically they're more aggressive and you're spending a lot of your time recovering from that. The chance of recurrence, relapse, the chance of the cancer coming back. A lot of patients are concerned, for example, if they've seemed to have gotten through this, then the thing that we see is the chance of cancer reoccurring, coming back. So they're in constant fear. So women that have been, they think that they're cured from breast cancer, they've had it reoccur, or they may have another cancer that emerges. My wife had breast cancer. That seems to be doing, she seems to be completely free there. But, last year she was diagnosed with bladder cancer. And so there's the C word again. Now they seem to have caught that early and so forth. But one of the things, well, Arnold, you asked the questions, chances of having cancer and being asymptomatic, very high. In fact, with lung cancer in women, we see 10 or 15% of those individuals have no symptoms. My daughter did not have, she was already stage 4 and had no symptoms. We actually caught that by mistake. So the things that we tell people, like colonoscopies and mammograms and things like that, these are all very important things, getting the message out for symptoms. Sometimes some of the symptoms are so ambiguous, but symptoms that hang on for a long time are going to be an issue. Unrelieved symptoms, you're going to find that people with cancer, that we will treat some things, but some symptoms we may not be able to touch. Either we don't have the drugs for it, or that we can't give them the particular medications at the levels that we want. One of the big ones is pain. Depending on the cancer, is a lot of times the pain becomes, especially when the cancer goes into bone. So it's one of the things. And one thing, Arnold, that you've got there is that they're going to look, one thing they look for prostate cancer is they look at the rate of rise. So, some of the things that we're getting, we're trying to find a lot of benefits for. Some of the medications people get with cancer may produce depression on themselves, or may exacerbate it or make it worse. A lot of people, body image, for example, in chemotherapy, they lose their hair. People that have, for example, some melanomas, they may be disfigured. Breast cancer patients, there's the issue. So there's a lot of body image changes. I've had a couple of students that have had, had to put in taken part of their intestines out, and the concern of what they're like with the bag on the outside, how people will think of them. People that have had mental health problems before. One of the people that was my daughter's age that ended up getting lung cancer also, she has been a major problem. She has 2 children, and one of the things that's happened is she got into severe depression. Then she went off of her meds. Then she came back and she wouldn't show up for chemo. She was kicked out of a couple of oncology offices that just said, we're not going to deal with you anymore because she was very hostile when she came in. She's very angry over the fact that she got the cancer. And so there's a lot of issues that come into play, but she was actually kicked out of 2 oncology practices. And she started self-medicating, so she went to rehab. They've turned it around now, but we don't know how much, quote, damage has been done during that time frame that she was going through all of this. One of the drugs, one of our close friends was just diagnosed with polycythemia vera, which is considered a cancer where her body is making too many red blood cells. And one of the things that they wanted to put her on was interferon. There's a clinical trial associated with interferon. And the doctor that was trying to convince her to go on the interferon trial told her, don't look up on the internet what it was, because that would discourage her from doing it. And she called me, and I just told her, I said, look, interferon has a lot of issues, not only with depression and anxiety, but my recommendation for her was, her oncologist was not the one that recommended that. It was a referral. And I told her I would go with her oncologist over that. So interferon has been suggested for a lot of things, but interferon treatments can cause depression and anxiety. We know in females, and I've learned this with experience with my daughter, that females with lung cancer are at a higher risk for depression. If they're living alone, that increases it. We see sometimes, I mean, my daughter did not feel helpless. It was like, okay, I got lung cancer, let's move on. But the girl I was telling you about, she really felt like that she was helpless and really couldn't do anything. That's part of the reason why she tried to cope through drugs. They're constantly fatigued if they have children. That puts a great pressure on them too. And a lot of the symptoms as they start emerging become very, very burdensome, especially when it, metastasizes to bone. When we see that they're depressed and not treated, you can imagine what's going to happen. Decreased compliance. Good example with the girl I told you. When we get them back in, a lot of times they've gotten much sicker, and we're dealing with a lot, so they're often in the hospital longer. The depression makes it worse. And overall, we just simply see that they do not do as well. Their prognosis with depressed and cancer is they do not do as well. So we have increased morbidity and mortality. Anxiety is a big issue. What happens is, one of the big things is the pain. If the pain becomes uncontrollable, and again, this can occur a lot of times once it metastasizes to bone, that can be pretty severe. Some drug treatments actually will increase anxiety, and so that has to be considered. A lot of people would have to go through their routine MRIs or CAT scans and stuff. That becomes very troublesome to them. Creates a lot of anxiety of getting into, having a CAT scan. And another thing is that some cancers, such as prostate cancer, there is this concept of called watchful waiting. Have y'all dealt with any patients that are sort of, that the cancer is under the watchful waiting? Just very curious. So some cancers, it's like sometimes the treatments that they've suggested in the past are actually worse and may actually increase morbidity. So like with prostate cancer, one of the things they've suggested is what is called watchful waiting, which basically is you don't treat, you wait till it moves to another step. But what happens with watchful waiting is patients sometimes, it's very difficult for them to consider that because they're thinking when they're not doing anything, the cancer is actually growing. But this has been, there's been prostate cancer as one example where a lot of times the early interventions created such a negative or negative impact with regard to the quality of life that it was just one of those things that it's very difficult. Not all patients do real well with watchful waiting, and not all physicians, agree to it. All right, let's move to another set of diseases, which is arthritis and osteoporosis. And a lot of people are like, why do we consider it? I mean, they realize it's a chronic disease. People with arthritis or osteoporosis, we know that they are, this is something that's not cured. But one of the things that we see is, why do you think depression would be a risk factor for osteoporosis? One of the things is that when people are depressed, they decrease their activity. And with decreased activity, we see degeneration there. We start seeing greater limitations with pain, as you mentioned, Rebecca. So it's really, a lot of it is lack of activity. And Janelle, I would say, I would qualify yours. I wouldn't necessarily say appetite. I would say nutrition. I would change that slightly. But a lot of times they hurt, and or they, you know, that they when they're depressed, they don't eat well. And part of that is they don't feel like eating, and when they do eat, they don't eat well. So what we typically see is people with lower education level um, that they don't do well. We see that workplace lack, it should be, I guess, lack of workplace support. They also see that there is lower social support in these individuals, and then pain. So these things tend to make depression more likely. They just feel like things are piling up on them and they can't do as much. Plus, as the arthritis or osteoporosis progresses, it makes it more and more difficult for them to go to work. So, for example, they start missing work, and then they start getting a lot of pressure for not being at work, or they feel like they may feel guilty that other people are having to pick up slack and things like that. The medications that we commonly see are NSAIDs and narcotics. Long-term use of NSAIDs. First of all, let me tell you, don't overlook the fact that NSAIDs can produce some psychological problems. But a big issue with NSAIDs long-term is they can affect your kidney function. They can also cause GI bleeds. So these non-steroidal anti-inflammatory drugs can have significant issues. They can raise your blood pressure. And then narcotics, the big issue, especially with opiates or opiate-like drugs, is going to be limitations with regard to whether you are, for example, this could affect your ability to drive. It could affect your ability to operate heavy machinery. If there's a drug testing program at where they work, this can create a problem. One company that I know of in another state, I was brought in, they instituted a drug testing thing. And basically this was, it was a small manufacturing plant, but their aspect of it was, even if you had a prescription, if you tested positive for benzodiazepines, opiates, let's see, those are the two big ones, I think, you couldn't work as long as you were testing positive. So somebody with a chronic disease literally couldn't work. They didn't fire them, but you were on leave without pay. And until you passed the drug test, which was, they had zero tolerance. So even though you had a prescription, legitimate prescription, and so forth, you couldn't work until you had zero drug tests on the drug test. We worry about drug interactions with these drugs. Again, arthritis, there's a number of other, since arthritis is considered an immune system, we have to be careful about that issue. Let's see. Yeah, let me cover asthma and then we'll take a break here. So we do see people with asthma have a lot of problems. There has been some data that show that there's a significant association with people that are either depressed or depressive symptoms and the severity of the asthma. And what we find is that the more frequent that they are having their attacks exacerbated, we find that that creates more psychological dysfunction. They start getting very nervous. They start getting depressed. They see their life changing because it's almost like they're waiting for the next asthma attack. And not only are they waiting for it, but they are sort of like anticipating what happens if it's going to be worse. So that is one of the things that we see quite a bit with that. Okay, let's see. Okay, so let's take a break, and we're going to come back and talk about, I'm not going to go so much into a lot of the chronic pain issues. I'm just going to talk about it because I think that you guys have already had some. I forget who was teaching yesterday. Didn't they cover chronic pain yesterday? If I remember correctly, was that? What was covered? Oh, did y'all have class a week ago? Yeah. And did they cover chronic pain? They covered depression. That was Myers and Paps that covered depression. Oh, okay. All right. So I'm going to cover a little bit about pain medication. And let's take our break. Let's see when I'm going to have you come back. Let's come back on the hour. And I'm going to tell you guys with my voice as it's going is we're going to come back and we're going to try to go through these slides. And we may finish up a little bit early today because my voice is rapidly decreasing. I'm going to go see if I can get some fluid. So I'll see you guys on the hour. Okay. Let's talk about a little bit about chronic pain in the elderly. So we see that pain, as you get older, you're going to hurt more. I mean, that's it. And in fact, we see a lot of elderly that's institutionalized because it's been very difficult for them to be taken care of by the family, and pain is a constant thing. Many of them may have limited movements and things like that. But one of the things you need to be aware of is that the elderly feel pain differently. They still feel pain, but what happens is that as you get older, you start getting degeneration of neurons in the spinal cord, plus the overall sensory awareness gets diminished. So what we do see, it's not uncommon for the elderly to, that their pain perception actually changes. No one's been able to demonstrate an alteration in pain thresholds across the ages. But we do see that sometimes because of this degeneration, the pain in the elderly is felt differently. The other thing we have to consider is that the elderly are going to be more sensitive to the effects of analgesics. So any drugs that we use, we have to be extremely careful. They may be more subject to the side effects of these drugs, and so we have to use lower dosages. It's very easy to overdose the elderly. When you look at the type of pain that the elderly experience, we have skeletal pain that tends to affect primarily the bones. We see things like osteoarthritis, rheumatoid arthritis. One of the things that happens from falling, they may have fractures. And one of the things when they get fractured is they get contractures, which means that things pull in and those contractures can push on nerves and create problems. We also see a lot of neuropathic pain. So this is nerve pain that occurs with diabetes, stroke, post-traumatic neuralgia, shingles, things like that can occur. So when the elderly start hurting, and this is not just unique for the elderly, but we do see from a chronic situation of pain, we get depression, we get insomnia, they can't sleep. Their mobility is impaired, sometimes because of the injury or whatever it is, and sometimes it just hurts too much. Our bodies don't recoup, it takes longer to heal. And what tends to happen is we withdraw. We don't want to socialize with people. Now I'm suddenly including myself as the elderly because I'm saying we do that. So ignore all that I just said. But we see decreased socialization, and sometimes that socialization is even worse because people don't want to be around them that hurt because it makes them feel bad. The other thing is that when you're doing assessments, in the elderly, and that's not just for pain, but, a lot of times they may not be able to see or hear what you're asking them, or if they're, having to read something or whatever. So sometimes you get inaccurate assessments. For example, you may list the drugs and ask them to take a look at this, and they may say, yeah, it's okay, and it actually may not be there. And then we see a lot of cognitive impairments. A lot of individuals that have had a stroke or dementia or delirium can produce some cognitive impairments, which can make it difficult to assess what's happening. Caregivers sometimes will interject, and sometimes that's good information, and sometimes that's what the caregiver wants, not necessarily what the patient may want. And then there's also some cultural or societal beliefs that may come into play with regard to whether a person, for example, males do not want to typically accept that there's pain there. What we really want to know is, tell us how severe is the pain right now? Is it mild, moderate, severe? What's the worst pain you've been? These are questions that you may ask. How would you describe your pain right now? How would you describe it over the past week, over the past month? Has it gotten worse? Has it gotten better? What helps? These are questions we talked about in physical assessment. How often do you do these particular treatments that seem to help? When you feel pain, do you not feel like eating? Are you got these tingling paresthesias? Are you not able to sleep? You know, these type of questions are things that we assess. We want to know how it interferes with their daily activity. And that includes how they're able to do their normal functioning things, with the things that they like to do, like their hobbies and stuff like that. This can give us an assessment and sometimes give us insight into really what's going on. So things that we look for, a lot of times, are they depressed? Are they not sleeping? Are they very anxious? Do they get agitated? Are they aggressive? Sometimes elderly people, they get aggressive and they refuse care because they think when you're trying to help them, you may be hurting them. In dementia patients, when you see an emergence of new behavioral problems, that could be a possible indices of pain. But typically, any moans, groans, or even crying could be signs of pain. So we have to be aware of that because they may not be able to communicate as well to us as a younger person or a person that may not have some cognitive dysfunction. So what we find is when we're treating patients with pain, one of the things that happens is they are very susceptible to becoming overly sedated, to becoming confused, bathroom problems, becoming constipated, which occurs with anybody on narcotics anyway, but urinary retention. So these can be worse in an older person, okay? So what we try to do is to find the best pain relief and the least side effects that can occur. Sometimes we take actions to address the constipation and things like that. For sedation, confusion, that may be only done by a reduction of dose. In kids, this is another, kids act differently to pain. A lot of people used to think children were not as susceptible to pain because their central nervous system was immature. But what we see is they pick up on cues. We find that a lot of times that children will basically, they pick up, depends on, their cognitive development, social development, emotional development. What we see is that a lot of times chronic pain, they tend to withdraw. They tend to regress to almost an earlier stage of development. But the other thing in assessing pain is we have to be careful because sometimes separating the parent from their parents to do an assessment can produce some anxiety that can be a real problem. Narcotic dependent patients, these are very difficult to deal with. Most clinicians do not like dealing with them. You have to treat them aggressively because they have a high tolerance. They may go through withdrawal. So we tend to avoid short half-life drugs. Those tend to be the worst scenario. But you've got to really work with these patients, and Dr. Norton will spend more time with you on these patients. I've included some slides here on HIV-infected patients. These we have to consider. Many of them may be depressed. Sometimes the HIV illness may produce a big stigma, both in healthcare and also with their caregivers. And we have to be careful because the drugs that we're using have the potential for some adverse effects. We have to be careful with that. And drug interactions. One of the big issues that we worry about is alternative therapies, is sometimes these alternative therapies that they may use may actually produce drug interactions. For example, we found out St. John's wort inhibited actually created problems and inhibited the action of some of the early antiviral agents. On pain medication, there's always a lot of abuse potential in patients affected with HIV because they will self-medicate, and sometimes they're using these drugs. Some of them may have gotten HIV because of a drug addiction. So some of the antivirals, you're very dependent on a pharmacy, the pharmacist to help you with. In fact, we suggest that the individuals go to a pharmacy that is working with HIV patients. We see that sometimes that antidepressants can interact with some of the antivirals and inhibit their action, as I said. And sometimes the antiviral may be inhibiting the action of the antidepressant. So a good example of this is ritonavir. It inhibits one group of enzymes, 3A4 and 2D6, but at the same time it inhibits 1A2. So drug complications or drug interactions can be very complex in this group. Excuse me. The tricyclics are pretty effective, but people don't stay on them real well. They get constipated, blood pressure drops, sexual function dysfunction occurs, they gain weight. These are things that HIV-infected patients are not necessarily wanting. Sometimes the sedation, constipation, and weight gain actually is beneficial or desirable in some of those patients. But we have to be careful, and since this population may be at a high risk for suicide, we've got to be careful because overdose, especially with a tricyclic, can be used. Many of these individuals will develop neuropathic pain, so the tricyclic is effective. The SSRIs have actually replaced a lot of times with the tricyclics as far as antidepressants. They simply are better tolerated and more manageable. With psychostimulants, one of the things that we see is that, especially in people with advanced stages of disease, these people may use these psychostimulants there. We always have to be careful or be aware of be aware of the potential for abuse. Thank you, Rebecca. I appreciate that. Now, the next few slides are things that you should have picked up or should be aware of in different pieces along the way. So it's really a review of some of the things we've talked about with different things. When we're looking at medication compliance, things to consider of, can the person really understand what you want them to do, what they should do? Multiple chronic diseases tend to be more difficult to deal with. You want to keep your dosing frequency as simple as possible. And you want to, once a day is perfect, but if you can't do that, you don't want a complex dosing frequency. We have to be careful about side effects. Certain side effects may not affect certain people. And what we may need to do is basically, it may be a point of finding out which side effect they can tolerate. How serious is the condition? How aggressively do we need to teach it? Do we need to, attack it? We need to let the patient know how likely the medication will improve the condition. We need to let them have a realistic response and make sure they understand why to take the drugs. The health literacy of the patient. When I talk about this with lower education, you got to make sure they understand what you're saying. But on the other hand, what you have to do is you have to be careful about the patients that go to Google all the time, because those can be sometimes more difficult to address than the ones elsewhere. Can they afford it? Do they have the insurance? Can they afford the medications? Does the patient have a good relationship with the provider? In other words, will the patient listen to you? Can you communicate with the patient? Are you communicating to a caregiver? These are things that we have to look at to try to figure out what's the best way to address compliance. When we look at this, it's important for the patient and the caregiver to understand the nature of the disease, the severity of the disease, okay? A lot of times people will either deny they have the disease or think they've been cured and therefore quit taking their meds. A lot of patients, once their symptoms feel better, they think the medications can be stopped. So we see a lot of people dropping or stopping their meds prematurely. We've got to avoid that. Beliefs concerning the effectiveness. Sometimes people have seen a commercial and think another medication may be better. So the one that you prescribe, they may ignore. Sometimes their friend or peer may say, well, this is what I use. Sometimes if they don't want to take the meds, they make up side effects. Some of the diseases may not necessarily have symptoms. Take something like hypertension, and they don't they don't feel sick, so why should they take it? Some people they think that they're weak if people know they're having to take medications. And some people have read about certain side effects on the media or in Google or whatever, and they either are afraid of it. My mom is a good example. She's always afraid of being addicted to medications. Anything that she has to take chronically, she used to worry about becoming addicted to. So these are things that you need to work in and talk about. If it's a complex thing like with inhalers, or if there's some weird thing about the medication, sometimes patients won't take it because they don't have the confidence to take it. So they think if they take it incorrectly that it'll be a serious issue. So just make sure that, a lot of times the pharmacist can help you with that. We see lawsuits and all these other things that come about, and that can be a big issue. So if you know a patient is taking a drug and there's been a commercial or there's been media attention about something, make sure that you address this. And some patients just, they don't, there's no positive motivation. In fact, some patients, it might be that, if I'm sedentary, everybody takes care of me. If I get feeling better, then I have to take care of myself. So you have to look at what motivates the patients and what can help there. So what we like to do is we tell our students to do this. Basically, for you need to tell the patient, here's what the medicine is prescribed. Here's why I'm giving you this medicine. This is what it's treating. This is why we're using it. And this is how it works in the body. And when you describe it, you need to use terms that they can understand. It's good to tell them, especially if there's a lot of options out there, up front as to why the medicine was selected. I mean, one of the things is, this is really unique for you based upon where your disease is and so forth. Go over with them the dosage schedule. Have them repeat it back to you. Write it down. These are things, call the pharmacist and have the pharmacist reiterate it also. Tell them about other prescriptions that they're taking, over-the-counter medicines they may take, or supplements. Tell them what may occur, what happens if you do get a side effect, how are we going to deal with it, and this is how we're going to monitor you. We're going to make sure the drug is working and make sure that we've got the right dose for you. When your prescription gets low, if you have to get another prescription, tell them what they need to do. Some prescriptions, if it's a Schedule II drug, something like you guys aren't prescribing narcotics, but an ADHD medicine, you're going to tell them they're going to have to come get another prescription from you. So we've touched on this, is the way to improve compliance: minimize the doses, preferably once or twice a day. Eliminate any medications that, if your medication replaces some or you don't need them, get rid of them. Basically don't just carry meds if we don't have a reason for it. If we have a problem with it, we might look at possible alternative dosage routes, sometimes maybe using a transdermal patch. And then the other thing is to consider things that we can use to decrease costs. The patient doesn't care that their hospitalization is going to be reduced by using this drug. They care on how much that their individual medication is going to cost them. Every time they come in, update the medication history. Make sure to go over it with them. If there's any new safety information, make sure you've incorporated that and made sure the patient knows about it. And then if you get an adverse event, report them. We talked about the med watch. Those are things that is important. So when you do a medication review, a lot of times these can become very cluttered because you got multiple prescribers, and a lot of people have not really given you a reason why they're prescribing it. Sometimes there's no stop date. They've just written a prescription. So what you should do is at least review that annually, but I would suggest reviewing it every time you see the patient, especially when taking on a new patient when they come in with their medicines. It takes time, and so that's sometimes very difficult. Another thing is sometimes people are reluctant to, quote, rock the boat. Patient's doing okay, but So why do anything? But the patient could be stable. But what we may see is that sometimes a symptom or something could be perceived as a sign of aging or something else. And other thing is sometimes somebody gets a little gastroenteritis or an infection, and that could result in a serious side effect. So what you want to try to do, uh, so Rebecca, with your patient with 17 meds, what you should do is just, it's all right just to simply say, check with your pharmacist to make sure there's no drug interactions. And that's just basically what you should do, is just say, you know, you take a lot of drugs, just check with your pharmacist, and that's all you really have to do. So, and encourage them to keep going to the same pharmacist. That's the other thing, is if you can get them to go to one pharmacist, there's good. So when we look at patients, especially chronic disease patients, the more the number of chronic diseases, the more the problem. The more medications, the more potential for a problem. The older they are, especially once they get greater 85 or older, that's an issue. And if they've had any prior adverse drug reaction, these are things that put a person at potential risk for drug-related problems. We see that other things, depression, low body weight, 6 or more meds I mentioned earlier, decreased renal function, cognitive impairment, all of those are things that can put a person at risk for drug characteristics or for drug-related problems. Now, a couple of things I want to touch on as far as drug interactions. One are SSRIs, serotonin syndrome, which occurs anytime which can be a potential when someone has any drug that elevates serotonin. So selective serotonin reuptake inhibitors, monoamine oxidase inhibitors, combined with those or with SNRIs, the net effect is that we get excessive serotonin that's there. And one thing I'll just tell you is that is a rare syndrome, but people, anytime somebody has a reaction that's on these drugs, they always call it a serotonin syndrome. It doesn't always occur, and but you need to be aware of it. And these, I'm going to cover the next few slides quickly because my voice is just about gone. So with over-the-counter medications, especially in elderly and chronic disease patients, make sure you include them in your medical history. Make sure you ask them, what are you taking? Are you taking any over-the-counter medicines? How often do you take them? What do you take? How much do you take? The ones that we worry about, non-steroidal anti-inflammatory drugs, as I mentioned earlier, they increase blood pressure. They can affect your kidney. They can decrease kidney function. There are some CNS effects. A lot of people don't wear them, but people that take certain NSAIDs, ibuprofen, naproxen, can develop confusion or dizziness. This can be related to an NSAID. The biggest thing we see is GI bleeds. Taking a lot of these non-steroidals can cause GI bleeds, and that's our biggest concern. Be aware of OTC drug interactions. So these can be looked up with Hippocrates or various other things. So look for those drug interactions. And then the other thing is that you can go on the FDA website and you can look under supplements, and they will give you where they have found adulterants. So adulterants are contaminants, or they are undeclared prescription products. So for example, some of the weight loss products actually have prescription medications in them. They're not supposed to be. We've talked about on-label, but let me just, so on-label is you're pretty much giving it just as prescribed. You're going to prescribe off-label on several occasions. And that's anytime, whether the dose is outside the dosage range that's on the label, if it doesn't include a patient population or an indication, or through a different route. So anything that is off or outside the label is considered off-label use, and it is fine for you to prescribe off-label. The FDA does not as long as you have a rational reason for going off-label. So for example, if you're using an adult medication, a drug approved for adults in a child, that's off-label. So when you prescribe off-label, make sure that you have thought through and have a rational reason for using it. So again, you can legally prescribe drugs off label. The FDA says we do not regulate the practice of medicine. And pretty much there's a lot of drugs that are used off label because the drug company is never going to go back and go through the testing to get them that way. So what we see a lot of drugs used high off label, notice psychiatric drugs, because a lot of drugs have not been approved, for example, in kids. A lot of drugs have been, for example, approved for, some of the SSRIs have been approved for depression, but not approved for anxiety, but some of the SSRIs have been. So this allows drugs to get to the patients quicker, and they are beneficial. So again, we will see this used in psychiatric drugs. We will see used off label. But again, there's sometimes where people are using off label that is, you know, really you would know that there is probably no reason for it. So reason drugs don't go back and get approved is basically it takes 10 to 14 years to get a drug approved, and a drug company is not going to pay for that. It's too costly, and they're not going to have it. It's going to be a small market. So what we see is off-label use is fairly common, especially with psychiatric drugs. The problem is you've got to consider there may be harm to the patient. The drug hasn't been approved by the FDA to be safe and effective in an off-label use. We really may not know what the appropriate monitoring is, so you need to, if you're going to use off-label, monitor appropriately. We don't know the adverse event profile. We don't know in children if there's going to be greater effects or worse effects. So we don't know the drug interactions. So, and there's really no oversight for use. So when we use off-label, this is not to discourage you to not use off-label, but realize that, again, we're going into a little bit of unknown territory. The biggest disadvantage is going to be liability to prescriber. You need to have a good reason to know why you're prescribing off-label. And chronic diseases, special populations, that's always an issue. So the drug, for appropriate off-label use, the drug should be approved by the FDA, which it's a prescription that's going to be, should be a no-brainer. Not approved for the particular use you're going to use it, but approved as a drug. There should be preferably peer-reviewed articles that describe its use. And really it comes down to, can you make a favorable benefit to risk assessment? And then even with off-label use, if you have an adverse event, report it to the FDA. That helps other people that are using off-label to have new information. You're not going to get in trouble. There's no illegal thing you do. So if you use a drug off-label, then basically just report it. For example, we see a lot of SSRIs that have been approved for one condition, but some SSRIs have not been approved for that condition. And sometimes you may use that other agent. That would be off-label. So it's acceptable and necessary. And in some patients, it helps provide optimal therapy. It should be based on a pharmacological principle, sound pharmacological principles, and give you a positive benefit. The biggest thing I can tell you on any patients is when you prescribe, it needs to be positive benefit risk, okay? This gets us the ability to get medications to patients faster. So, and again, if you can publish it as a case study, that's always helpful too. I know that's sometimes difficult, but that's something we try to encourage. Guys, this is about as far as I'm going to go, and I'm at the end of the slides anyway. So let me just tell you this. Aiden is going to put up the quiz. He's got the answers. He'll post the answers for that. I'm going to send you a couple of articles that I told you. I'll have Aiden post them on Moodle. Your test for this material will only come from the red areas that I've got cited. And basically, it'll only be 10 questions on my material. So it's going to be a fairly short quiz. And I'm going to try to have that to Aiden by tomorrow. So thank you for bearing with my voice. And I don't feel real bad. It's just my voice is about ready to go. You guys again, I have appreciated you as a class. I really appreciate, wish you the best. If you ever have any questions, do not hesitate to contact me. Aiden, once again, it was great having you as a TA, and I thank you for all you've done. Guys, you have a great, great weekend, and I will see you later. Bye.
My pleasure, Doctor. I will run the quiz as soon as I'm done with the attendance.
Thank you.
Awesome. Have a good day. Please, everyone, don't go anywhere. After closing the attendance poll, I'm going to run the quiz.